Good afternoon. President John Mahama signed the Legal Education Reform Bill into law, ending the Ghana School of Law 66-year monopoly on professional legal training. The new law opens the door for accredited universities to run professional law programs. Attorney General Dominic Ayeni said implementation starts immediately with the creation of a Council for Legal Education and Training. The council replaces the General Legal Council and will accredit law schools offering the law practice course for LLB graduates preparing for the bar exam. We will hear from the AG shortly, but first, here's President John Mahama after signing the bill into law.
Regulate legal education and ensure the highest standards in terms of legal education, but also to open up the space, for more opportunity for legal education in Ghana. This particular act has been one that many aspiring lawyers have been looking up to. So it's been signed.
That's President John Mahama in a brief ceremony signing that particular bill into law. Let's now listen to Attorney General Dominic Ayeni on the immediate implementation of the reforms.
This morning, His Excellency the President of the Republic of Ghana has signed into law the Legal Education Bill 2026. As he himself said, this is a much anticipated reform bill or reform law that is supposed to radically reform legal education to create equality of opportunity for persons aspiring to be lawyers in this country. As a result of the fact that presidential assent has been given to the law, we are now ready for implementation. Immediate implementation will start with the establishment of the Council for Legal Education, which is the body that will oversee legal education in the country. We'll also start the process of accreditation of the law schools that will be running the law practice course for those who have LLBs and desire to write the bar exam. All of that will start this year. We'll be making budgetary provision for the implementation in the 2027 budget to be announced by the finance minister in November this year.
Well, the President also signed the Value for Money Office Bill into law. Listen to Finance Minister Kasiel Atoforsen.
President this morning signed into law the Value for Money Office Act. This singular signature and assent will mean that going into the future, the Republic of Ghana and the government of Ghana will curtail public sector expenditure that has actually risen as a result of overinflation of government contracts. What we seek to do going into the future will be that we will set up the office and all single source procurement will have to go through the Office for Value for Money. In the past, the legal division of the Ministry of Finance has been the one that conducts Value for Money Office. They did not have the requisite skills and ability to deal with value for money. And so what we've done is to properly institutionalize the Value for Money Office. President Mahama, as part of his campaign pledge, promised to establish the Value for Money Office, and today he has graciously assented to it following Parliament's passage. I want to use this opportunity to assure the people of Ghana that the menace of public sector pardon of contracts and overinflation of contracts will be curtailed by this signature. What we seek to do is to use the next 6 months to properly constitute the office, nominate the leadership of the Value for Money Office, and constitute the technical team that will ensure the implementation of the Act. And so I believe that beginning 2027 January, this office will be fully implemented and Ghanaians will see the need of a Value for Money office. I have seen Value for Money office being operated in other countries, and I can tell you for a fact that if there's one single office that can pay for itself from day one, it is the Office for Value for Money Office, because it's reduced public expenditure and obviously create fiscal space that will be used to develop other sectors of the economy. Thank you.
We're back from this break with more. Hello again. Rockson-Nelson Dafeamekpor is the Majority Chief Whip. He's joining me on the telephone lines right now for a conversation on the passage of the legal education bill into law by President John Mahama. Mr. Dafeamekpor, welcome to the program. You have always been a proponent of this law, which has now been passed by the President. I want to pick your initial thoughts on that.
Thank you very much. Good afternoon to your viewers. I'm glad to have joined you on this momentous occasion. Yes, the accent to the law as it is technically means that this is the new law governing legal education in the country. We have processes for implementation. If you read the law carefully, from about section 22, 23, you see that we have standards for accreditation. So accreditation processes will have to be gone through. 23 talks about requirements for accreditation, or requirements to obtain accreditation. So all the faculties as we know them, or the law schools as we know them, that are currently training LLB, or training for purposes of obtaining LLB, I have to put in the application for accreditation purposes. Then also the law school as it is, because the law school has been re-established under the law as a separate training institution for the professional program. And so the law school itself, plus other schools that are assisting it to train students as we have it now, also have to put in a request for accreditation. So we are looking for some speedy processes to give effect to the law in terms of implementation.
The question on the lips of many people is that the people, the law students who would have gone to Makola this year, does it affect them? Are they still going to Makola, or?
Makola itself will have to apply for accreditation. So there's nothing like Makola under this law, because Makola itself will have to be accredited. But the law under the saving provision, under the transitional provision, which is section, if I believe, section 93, the transitional provisions makes it clear that the current system of training professional lawyers and the current students who are undergoing that training as we speak will be trained under the same system as though they were trained under the new law. If you understand what I'm saying, we call it a saving provision. So those who are in the school now will continue to train as they've been admitted to train. So, but the law will recognize that process. What the law is introducing is a wider access, either to only the Ghana School of Law has the monopoly to admit, as it were, LLB holders to train as professional lawyers. Under the new dispensation, it is no longer the case, because the Ghana School of Law itself is a candidate to be assessed and accredited, together with all the other faculties that are training LLB holders. So what we are looking forward is some expeditious process to make sure the accreditation processes are quickly done, so that the regular academic year, or the regular academic year for purposes of doing the professional training is not affected or disrupted.
So does it mean that the law takes effect immediately?
Immediately, yes. There's no delay. That is why if you had attended, Hello?
I'm listening to you.
That is why if you heard Attorney General soon after the presidential assent, he made it clear that measures will be put in place quickly for the implementation of the law and for accreditation purposes. So there's no delay. And then he also hinted that because we are going to establish the what we call the Council for Legal Education Training, which is a statutory body, which is actually the regulatory body to regulate the training of lawyers and legal education in the country. We need some funding. We need budgetary allocation. So that will quickly be taken care of also this year. And then we are going to have officers. We are going to have a director general. We are going to have registrars. So all those things, it comes with budget. So if you heard him, he hinted at about engaging the finance minister quickly to make sure some interim budgetary allocations will be done so that these structures can take off quickly to affect the implementation of the law.
There's been a long write-up by your colleague Vincent Eko Asefua in Parliament. He's part of the minority, and he says that you are causing confusion and deception. I want to rephrase and summarize portions of what he's written for you. They say that you, Rockson-Nelson Dafeamekpor, are creating confusion over whether prospective students will still be required to write the Ghana School of Law entrance exam this year. And they say that you had earlier suggested there will be no entrance exam because no official announcement had been made by the Ghana School of Law. However, they are arguing the Independent Examination Council had already scheduled the exams for July 31st. What do you make of these accusations by the minority to you?
Now, first of all, I responded to that letter formally. I responded. I don't know whether you have seen my response.
Yes.
I issued a statement in response. First, Asefua failed to cross-check for the IEC whether indeed the IEC issued that notice. Because when I cross-checked, the IEC didn't issue that notice. So that notice is no longer featuring on the website of the IEC. And so I asked him whether he knew what he was speaking to. Then two, I also asked him that as a lawyer and as a member of parliament who participated in the passage of this bill, didn't he pay attention to the provisions in the law that when it is given assent to will take effect? There's no provision in the law that says that the law will be delayed upon assent. Never. And so he rather tried to hoodwink the people and thought that the delay in giving assent to aid meant that the law will not be implemented. I have maintained that once the law is given assent to, its implementation is immediate. And if you read the law, every section of the law becomes effective. And so if every aspect of the law becomes effective immediately, where lies the confusion I have supposedly claimed that I have thrown out? He has ceased to pay attention to the processes and decides to do politics with everything. But that's not what we want. This is a major reform that we are introducing. And I believe that it's in the interest of all of us to ensure that the implementation is effective so we can benefit from it. What we are looking for is benefit. Look, my brother, as we speak, there are over 3,000 Ghanaians who have obtained LLB in Ghana, and because of the strict checks, because of the lack of pay, are training in Sierra Leone, are training in the Gambia, are training in Zambia, are training in Kenya, are training in Tanzania, are training in Rwanda. And in those countries, they pay as international students. So if this piece of major legislation is going to reverse that trend, can you imagine the forex implication for Ghana? When a lot of Nigerians, I trained with a couple of Nigerians because they too were having difficulties. So they came to train in the law school. They were my mates. They are big men in Nigeria now. Can you imagine the reversal in trend where Nigerians will come here, Sierra Leoneans will come here, people from Kenya and Zambia will come here to train.
So, Mr. Dafeamekpor, I want you to clarify for us in layman's terms, prospective students who are supposed to write the Ghana School of Law entrance exam this year, will they still go ahead and do it?
There will be no entrance. Let me be very clear.
No, I want you to emphasize on that. Yes or no?
I am under the entrance exam as we know it no longer exists.
Okay, effective immediately.
Effective immediately.
Okay.
Now, what if Ghana School of Law, upon accreditation, decides that I still want to admit people through entrance exams? Even that will be subject to approval by the Council for Legal Education and Training. They cannot do so suo motu. Do you understand what I'm saying?
Right.
So if because the admission processes will be standardized across the country. One school cannot do another thing from the other. If there's a certain way of admitting students to the accredited law schools, the standards will be the same. The processes of admission will be the same across all the law schools. People have refused to read the law, and they are making their own conjectures. But I want to urge them to take their time and read the law and understand the structures that have been introduced. And so we must rather be patient for the schools that will apply for accreditation to do so. Let them go through processes of verification, authentication, inspection, and when they get accredited, we take off.
And what safeguards are in place to ensure that the quality of lawyers called to the bar are not compromised? Because these are also concerns that have been raised by opponents of this particular bill, which has effectively become law. Now,
under the new system, there's a lot of professional training components into the training. Hitherto, in the professional law school, we only did advocacy, legal accountancy, conveyancing, moot courts, drafting. Even drafting was optional. But every lawyer's tool is drafting. You have to draft processes. But it was optional. It wasn't compulsory. In the new system, there's the introduction of a lot of practical training, just to sharpen and improve the quality of the lawyers that we produce. So under the new system, the standards have rather been heightened and made more tougher. So we are going to get better lawyers coming out of this new system than we have now.
There are also concerns that the various faculties of law across the various universities across the country might also try to take advantage of this, because that means more law students will be trooping into their various faculties and perhaps take advantage and maybe even increase their fees or something like that. How or what safeguards are also in place to ensure that the various law faculties across the country do not take advantage of this?
Now, the Council for Legal Education and Training will be operating with, under this law, will be operating with a lot of guidelines and regulations. We have, by the law, asked the minister responsible for justice to, as it were, come within 12 months with a regulation to properly implement the law. Those ones who deal with the guidelines regarding fees and all that. In any case, the fees will rather be lower. Okay. Because if University of Ghana School of Law charges a higher fees, I will have an alternative in the University of Cape Coast School of Law, or an alternative in Ghana School of Law, or an alternative in Jimpa School of Law, or UPSA School of Law, or Tech, or Tamale, or Central University, or CAF, or Wisconsin. So it doesn't. The logic is not. It doesn't make sense for anybody to rather argue that the more law schools that we have, the more options we have, fees are rather going to go up. This should rather be the argument against the current system that it's because we have only one law school. So they have a monopoly. So even when they increase fees, you ask for a rebate and they don't listen, you are compelled to look for the money and go. But when we are going to have about 10 law schools accredited or more, depending on how the accreditation processes go, how are they going to charge fees? Are they going to gang up? You can't do that in a free democracy.
And how soon will the universities be granted accreditation to run the law practice course? What criteria do they have to meet?
If you read section 22 of the law, it says the council shall, in collaboration with the Ghana Tertiary Education Commission, set standards for the accreditation of institutions to offer or provide law practice training. So the first step that we will have to do is to set up the council for legal education and training, and then set up and then make the statutory appointments under those. So the point I'm making is that the structures that will help to implement the law quickly will have to be put in place, and that is where our focus is on. That the appointment for the constitution of the council should be with immediate effect. The appointment of the Director General, the Registrar, all those things must be a matter of urgent concern so that it will help to put the structures in place where the universities can now apply to those structures for purposes of accreditation.
Right. Rockson-Nelson Dafeamekpor, thank you very much. Is the Majority Chief Whip in Parliament. In other stories this afternoon, the Ghana Medical Trust Fund, also known as Mahama Care, has announced plans to establish 3 cancer treatment centers in Ghana. This is in response to the increasing number of cancer cases and the growing need for comprehensive care. Listen to Administrator of the fund, Obobia Dako Opoku, outline the plan at the Government Accountability Series.
Looking ahead, our vision for the Ghana Medical Trust Fund is bold, ambitious, and transformational. First, we envision massive nationwide investment in health infrastructure and equipment. Our long-term goal is to establish comprehensive oncology and cancer centers across Ghana. This vision is informed by the current reality that Ghana remains severely constrained in oncology care capacity. As mentioned earlier, there are only 2 radiotherapy machines within the public sector, and patients from across the country must travel long distances and endure prolonged waiting periods to access care. In some cases, patients wait between 2 and 3 months before receiving treatment. Additionally, the country faces significant shortages in PET scanners, MRI machines, and other specialized technologies. It is therefore our vision to establish at least 3 comprehensive cancer centers capable of providing integrated diagnostics, chemotherapy, radiotherapy, and advanced treatment modalities, including technologies such as the gamma knife systems and state-of-the-art diagnostic centers across the country, starting with the Ridge Hospital as our pilot project.
Well, she also responded to criticisms over possible duplication of the work of the National Health Insurance Scheme.
Let me state clearly that the Ghana Medical Trust Fund complements and does not duplicate the work of the National Health Insurance. Our national healthcare financing architecture can best be understood as a 3-tier pyramid. At the base of free primary healthcare, which delivers essential primary health care services such as interventions in disease prevention and health promotion. At the middle sits the National Health Insurance Authority, which covers broad outpatient and inpatient health care needs. At the apex is the Ghana Medical Trust Fund, which focuses on specialized tertiary level care and supports patients where the National Health Insurance Scheme coverage is limited or unavailable. Secondly, while the National Health Insurance Authority is principally a health financing institution offering financial risk protection, the Ghana Medical Trust Fund, by contrast, has a broader specialist mandate under Act 1144, covering patient support, infrastructure and equipment investment, specialist training, and medical research.
Well, let's get on to Zoom right now. For more on this is Health Policy Advisor at the Ghana Medical Trust Fund, Dr. Norbert Kipo. Welcome to the program. What more can you tell us about the change?
Thank you very much. Good afternoon, and thanks for having me on the show. So the Ghana Medical Trust Fund was established to mobilize resources for the management of chronic non-communicable diseases, of which cancers are of great interest. Having consulted the Technical Oversight Committee and the other stakeholders, the Board of Trustees has approved that we start with the cancers in focus. This is because, based on the actuarial studies, we would have to start gradually to ensure sustainability. But then we conducted a needs assessment tour to the teaching hospitals, regional hospitals, and the major referral facilities across the country to assess the readiness of these facilities in terms of human resource capacity as well as equipment as we prepare to roll out the patient support program. But the findings were very revealing as far as cancer care is concerned. We have few facilities that have the ability to offer comprehensive cancer care. In terms of radiotherapy, we just have 2 machines in the public sector. That's one at Konfanochi Teaching Hospital and the other at Kolebu Teaching Hospital. And because of the large volumes of patients who access these facilities, they break down frequently and the downtime is usually high. So some patients sometimes would have to wait as long as 2-3 months before they have access to treatment on these machines. And because of the location, the geography does not favor certain people who have to travel long distances to be able to use this equipment. So as part of our long-term vision, the Ghana Medical Trust Fund wants to invest heavily in setting up oncology centers across the country. This should reduce the travel time for individuals and also make the specialist care available and ready to people regardless of where you are. However, putting up these centers requires a lot of work, from the feasibility studies to regulatory approvals to the financial capital investment. This is huge. So we are exploring all avenues to be able to put up these centers, and the president has instructed that we take the private-public partnership model where we invite private investors who can inject some capital in this with the support of the public sector, providing space, providing the human resource to be able to set up these cancer centers and support our teeming Ghanaians who are battling challenges with various forms of...
That was actually going to be my next question. So if you are calling on private individuals, private organizations to come on board while you've already launched the program, do I take it to mean that you really did not plan through?
Not at all, not at all. So establishing this is to complement what we already have, the existing structures we have. As we speak now, there is cancer care that's happening. I mean, radiation therapy is one of the options available for cancer treatment, but the other options include surgery, chemotherapy, and of course, the various forms of nuclear medicine. That already the country has the capacity to do. So we have people who are able to undergo surgeries to take out their tumors in the various stages. We have people who are undergoing various forms of chemotherapy, and there are still people who benefit from radiation therapy. But of course, we have to upgrade our capacity in terms of equipment and infrastructure and human resource. And this is the government's commitment to ensuring that we are able to expand the capacity to be able to train. If we want to wait before we establish this would take 2-3 years. Because like I mentioned, this involves a heavy capital investment, regulatory approvals, and all that. But of course, we have people who are diagnosed of cancer almost every day. And for that reason, as a country, we have to put in some measures in place to be able to support these patients go through their treatment. So one of it is the financial support, the financial risk protection that the Ghana Medical Trust Fund seeks to offer patients who are diagnosed with cancers. And aside that, we are supporting the training of specialists to build the human resource capacity, because it's not just enough having equipment. You need people to be able to manage this equipment, make accurate diagnosis, and offer the treatment. So we are also engaging the various colleges in strategic partnerships to build the capacity of our health workers, and of course, then the infrastructure and equipment come. So it's a holistic approach we are taking to deal with this whole cancer situation. Financial support, support for training of specialists, infrastructure investment, and of course, medical research into the prevention, diagnosis, and treatment protocol of these conditions. So it's a holistic approach. So all of these can happen concurrently.
The structure that is currently in place, where did the funds come from?
Would you want to provide more clarity to your question? When you say the structure in place, what exactly do you mean?
You are saying that you are calling on individuals, private individuals, to come on board. And of course, you have already started something. The something that you've started, where did the funds come from? That's what I'm asking. I don't know if you get me.
Right. So at the moment, from the administrator's presentation at the accountability series, so she talks about the oncology centers as our long-term vision. So we want to deal with non-communicable diseases. But like I mentioned, these challenges come from different sources, from equipment and infrastructure to the financial burden it poses on individuals to human resource to research. So we are working on all these components concurrently. Like I mentioned, we have invested 36.2 million Ghana cedis in the training of specialists already. We have started, we have done the pilot phase, and there are processes underway to roll out the official patient support program with cancers in focus. So we have updated the standard treatment guideline. We have updated our medications list to include newer technologies. We have developed a robust IT platform to help in patient onboarding, treatment management, claims management, and all that. And we have set up a committee to put up together a research fund where individuals and institutions that conduct research that are relevant to the mandate of the Ghana Medical Trust Fund can reach out for support to conduct research, such that our protocols are based on empirical data and evidence. And all this is financed by the budgetary allocation that was made for the fund in the 2026 budget reading. So we have some funding coming from government. We've had individuals and corporate Ghana contributing significantly to this fund. And for now, this is what we are using to roll out. But of course, like I mentioned, based on our needs assessment, or there are gaps in the health sector that we are working towards fixing. And that's why we are inviting more partnerships to assist us solve this problem and offer the best care we can to our patients.
Who qualifies to enjoy this program?
So this is a fund for all Ghanaians. So to benefit directly from this fund, you first have to be Ghanaian. You have to be an active member of the National Health Insurance Scheme, a card-bearing member. And of course, you should have a condition that falls within the benefits package. So this is important because it helps us prove that individuals are going through all the systems of healthcare, from free primary healthcare to NHIS. And then the Ghana Medical Trust Fund comes in where the NHIS has very limited or no coverage at all. When it comes to the benefits package, we are offering comprehensive treatment for breast cancer, cervical cancer, prostate cancer, the childhood cancers such as leukemia, lymphoma, soft tissue sarcoma, retinoblastoma, nephroblastoma. So an individual who has this condition is Ghanaian, registered on the National Health Insurance Scheme. When you visit the hospital for your appointment, your clinician will then put in an application through the IT platform. It comes to the fund, the technical team reviews, they give approval, they communicate this approval to the facility that's attending to you, the specialist that's attending to you, as well as the patient. Then treatment commences, and monthly the facility submits its claims for reimbursements to be made. So this is the framework, and this is the eligibility criteria for individuals who want to benefit from the fund.
Usually we see that some Ghanaians who suffer from certain kind of diseases are airlifted outside of the country to seek further care. Is there any policy in place from the fund with outside health facilities to ensure that if there is a case that is beyond the ability of Ghanaian health professionals, they are airlifted elsewhere to be treated? Is there anything like that in place?
So the act that established the Ghana Medical Trust Fund, Act 1144, does not permit the Secretariat to support or fund any treatments outside the borders of the country. So for now, we are focusing our efforts on building the capacity locally so that such treatments can be handled in country. But as we speak now, the act that established the fund enjoins us to only provide support for treatment that is happening in country.
What's the long-term goal of this?
The Ghana Medical Trust Fund was set up to solve a challenge, and that is the rising morbidity and mortality associated with non-communicable diseases. over the years, we heard of malaria, HIV, AIDS, tuberculosis, and the rest. But now we have moved on to conditions that, as it were, it's not transferable to another person. Your hypertension, diabetes, cancers, kidney failure, and the rest. And these conditions account to close to 45% of all deaths in the country. So nearly 1 in every 2 deaths in the country is attributed to these conditions. So the government set up the Ghana Medical Trust Fund to mobilize resources such that we can treat such conditions in country. Support patients who have to deal with the catastrophic cost that comes with it. Mind you, when individuals are diagnosed, not just the individual, but the entire household, within the first 5 years of a diagnosis, 3 out of every 4 fall below the lines of poverty. This is because you continuously pay for your treatment. It's not a one-time treatment. And no matter how financially stable you are, due to the long duration of treatment with time, it begins to affect families. So we are offering that financial support. We are also investing in infrastructure, because sometimes some patients, it's not an affordability issue. It's an issue of access. They can actually pay for it, but then the service is not available to them where they live. So we are trying to provide that infrastructure so that patients do not have to travel long distances to access that care. For some people, it has to do with the human resource. They get into the facility, the equipment may be there, but we don't have the surgeon to conduct the procedure. We don't have the pathologist to analyze the samples. So then we are referring you. So we are also building capacity. And then in some cases, we just don't know what's causing the illness. We want to develop our own protocols, taking into account our own peculiar situations. And then that is the need for research, such that our interventions are grounded on empirical evidence. And this is why the Ghana Medical Trust Fund was set up. So moving forward, we envision a health sector where individuals do not have to choose between their lives and their livelihood, where individuals are not denied healthcare because of their inability to pay. We are looking at a health sector where people are not disadvantaged by their geography. Because the person lives somewhere, he's unable to access certain services. We are looking at a health system where individuals can walk into any hospital close to them and would get the necessary specialist tertiary level healthcare. And this is the health sector that the Ghana Medical Trust Fund has envisioned. And we are hoping that with the support of all Ghanaians, corporate society, and the necessary stakeholders, we should be able to achieve this in the foreseeable future.
Is that to say that persons who are able to afford that will have to pay?
So the Ghana Medical Trust Fund is here to support all. I believe that no matter how wealthy you are, like I mentioned, due to the chronicity of the illness and the fact that the payments keep repeating periodically, at certain points, people begin to feel the financial burden, not just on them, but their families. And many Ghanaians are unable to afford. For example, the average cost of treating non-communicable disease is about 56,000. Not many Ghanaians can afford to spend 56,000 on healthcare, considering the fact that they have other financial obligations like paying school fees, supporting their family, supporting themselves, and all manner of expenditure. So a lot of people would actually need to access the support. But for individuals that can afford it, we encourage them to actually pay as their form of supporting the fund and not burden the fund. There are individuals who may have some forms of insurance from their workplace and other places that can actually help them handle the cost of this treatment. So instead of overburdening the fund and putting all the pressure on government, we encourage individuals who can actually pay for the cost of their services to do so that we can reserve this fund for those who are most vulnerable and actually need the support of government.
How about those who cannot pay entirely, but perhaps could be able to support? Are there also persons that are welcome?
Yes. So like I mentioned, this fund is for all of us. Once you meet the eligibility criteria, Ghanaian, active member on the NHIS, you have a condition, you are eligible to access support. So for individuals who feel there is a need, who for some reason cannot afford the full cost of treatment, you are free to onboard as a beneficiary of the Ghana Medical Trust Fund, and will readily support and offer the comprehensive service that you require to restore your health. So it's open to all Ghanaians as long as you meet the eligibility criteria.
Is there a cap that someone must meet, that you can't go beyond this cap, and if you do, there has to be support coming from elsewhere? Is there any cap?
So we have developed a standardized billing structure, taking into consideration all the services, diagnostics, procedures, medications for the various conditions. We have also taken into account the different stages of the cancer and also the different treatment modalities that are available for each stage, and we have a billing structure. So based on the billing structure, it automatically puts a cap for that specific condition. But as it were, there are individuals who today have a cancer, upon treatment in 2 years' time or 3 years' time, could have another condition which may be covered under the fund. As it stands now, there isn't a cap to say that if we have exhausted, say, 500,000 on your care, then the fund ceases to operate. But this has come up in most of our policy engagements, and it's something we are looking at. And based on our actual analysis, it is something that we hope to consider. But as I speak to you right now, the standard billing structure sort of serves as a cap for each of the various conditions, depending on your treatment modalities available, as well as the staging of your cancer.
Dr. Norbert Kipo, thank you very much. He's with the Ghana Medical Trust Fund. In other stories this afternoon, the Minister for Local Government, Chieftaincy and Religious Affairs, Ahmed Ibrahim, has reaffirmed President Mahama's commitment to partnering traditional authorities to accelerate development in the Central Region. Speaking at the coronation of the NDC's Central Regional Chairman, Richard Kofi Asiedu, as Development Chief of Aguna Nyakurum, the minister announced plans for the construction of a major community center expected to be completed within 12 months. The following report has more.
Crowned under the stool name Nana Asiedu Keteke I, NDC Central Regional Chairman Richard Kofi Asiedu was installed as Development Chief of Agona Kwenyako in a colorful traditional ceremony, attended by political figures, traditional leaders, and residents. Among the dignitaries were Chief of Staff Julius Debra, NDC National Chairman Johnson Asiedu Nketia, Ministers of State, regional party executives, and traditional rulers. Swearing the sacred oath of allegiance before the Agona Kwenyako Hene, or therefore Dr. Ampem Dako V, Nana Asiedu Keteke I pledged to use his new role to champion development in Kwenyako.
Menim Kwenyako problems. Na Kwenyako problems is only me. Enti nyome bi e beta ni bia no, ye beta ni hair song. Nia esi makoma so pa ne se Kwenyako kure yebenya eduma ama mbebu no yewie no sa yehia basic infrastructures major one year roads and a hospital a fatakoi young kromano wo Ghana and abuchi e ka ye humom say ye boa say ye be hospital no and so yentumi enye na mena na say some pempensu ya ma be ye nkoso hene wo krum hai sabe ede yempenfo akase mienu pa be pie krum ha no obeboa me na adia eda menu so no metuma ya makoi ejuma esi menu so a me be ne first ese mewie ene Kwenyako community center.
The Local Government Chieftaincy and Religious Affairs Minister Ahmed Ibrahim reiterated President Mahama's strong backing for the new chief, announcing plans to collaborate with the traditional leadership and the area MP to deliver a landmark community center project for Kwenyako within the next year.
President Mahama said, on the chief of staff, and the party for the one Nana Asiedu Keteke first, I am moving it's a perfect place, and the presidency is solidly behind you. Going forward, and chief of staff to me, Mama Sonte, President Mahama, I can't do the song. Project Ewa, Resante, San Mikasi Day, we say a percent now. So a day yet in a last year because I can affect the Sabano, and I if you have a government of 4%. Yamia Duma, I say, not for a community center.
On his part, the NDC National Chairman Johnson Asiedu-Nketia praised the regional chairman's leadership qualities, describing them as the basis for his elevation to the traditional role.
Results were 2024 election. Like I said, party chairman I was central region Hada. In the Musay, Papano, say, Oye, Papa, and Koya, and by the former friend, dear one of Master. Becca Swama, Ghana 49, Taco Old William Musay, or here, and politics. Then so, Yanka or here, you will move and so to we are honor Yamanuan, Oya and Kosua in it. And yet, the Bushel Waboya, and the Araso, and the Rosia. I don't think so. I read this or purport. I'm here to tell my children.
More than 200,000 Ghana cedis was raised through donations towards the construction of the community center project. Carlos Caloni, JoyNews, Kwenyako.
Return from the break with more. Welcome back. The Emergency Medicine Society of Ghana, EMSOG, is warning against what it describes as an overemphasis on blaming individual healthcare workers in the death of Charles Emisa, insisting the tragedy exposed deep-rooted failures within Ghana's emergency healthcare system. In a statement reacting to the findings of the committee chaired by Professor Ajumanbedu Akosa, EMSOG argued that the country's no-bed syndrome is the result of years of underinvestment, inadequate emergency infrastructure, workforce shortages, overcrowding, weak referral systems, and limited emergency care capacity. All their concerns have been re-echoed by a number of stakeholders in the health sector, including former presidential advisor on health, Dr. Anthony Insiasari, who believes more heads, including a member of the committee who is the head of department at Kolebu, must roll.
2018, when we lost the 70-year-old man. Unfortunately, he went to 7 hospitals. This one went to how many? 3 hospitals. And it beats my mind that there are some of the hospitals which were involved in the 2018 no-bed syndrome death of the 70-year-old man, who was also part of this, i.e., Greater Accra Regional Hospital, RICH, and Kolebu Teaching Hospital. Then there's a committee which has been set up, which is, to me, is a fact-finding committee. It's not a court. Maybe you have to get it right. It's fact-finding committee. Later, I'll tell you about. I have some few issues with it. They've done a very good job. They've brought out some things, but I believe that they should have gone a bit further, because the young health professionals who were supposed to see this patient, which maybe they didn't say because there was no bed. There are people who are their supervisors. I went through the list. Some of them are medical officers. Only one of them is a senior medical officer. So there's an immediate supervisor. Professor Sabene says something that if you go to any hospital, there's a duty roster. The duty roster, especially in the big hospitals, in our premier hospital where I trained in Kolebu, I've trained there before, I've worked there before, so I know what it is. That there's a consultant or senior specialist or specialist who is supposed to be on duty that day before the residents and then maybe the junior doctors who are there. The same thing with the nursing hierarchy. My issue is that I didn't see their names also mentioned anywhere. If I were part of the committee, they are the people that I would take on. I've also realized about the committee's composition. There is one of the committee members who is the head of Department of Kolebu Accident Emergency Department. He should have been questioned, but not he questioning people. he should have been questioned. Was there any duty racer? You are the head of department. Where were you when this thing happened? Because before a junior staff or junior health professional can take such a decision, there is maybe some system which is in place which have encouraged that person to do that.
We've also been hearing from renowned pathologist and fellow of the German Academy of Pathology, Professor Paul Osei-Sampene, who says strictly upholding the World Health Organization standard in emergency healthcare is the only guarantee to forestall future occurrence.
Emergency obligations, what do we call it, responsibilities, duty of care have been spelled out in 2021 resolution at WHO, that's the WHO World Health Assembly, where they passed a resolution, we called it 72.6. So I believe that the doctors, if this patient to the ward, there is no bed, and that we can improve a place where
you are talking about the same places where people are made to sit in chairs to be treated. People are lying on mats or something on the floor. So why are we refusing to recognize that some of them may have been overwhelmed at the time and they couldn't take extra patients?
Well, let me just say something. Look, I'm saying that in cases of emergency, please let us take note of, in cases of emergency, such as what happened during the COVID time. COVID time was an emergency. There was no point going to tell somebody that we need to have a special place for them. That's why Confanoch at a point, or the ministry at a point, even improvised by erecting tents all over the place, cordoning a lot of areas for people to be seen. So an emergency case, WHO does not joke with emergency cases. And they have actually passed a resolution. I'm telling everybody listening to me, that we can go back to 2021, the resolution that was passed by the WHO in cases of emergency.
And beyond the administrative sanctions, youth activist Ivan Che Innocent says the family must consider legal suit in the matter to serve as a deterrent. He spoke on Prime Insight on Joy Prime.
Condemn the health officials now.
Oh, definitely those who are involved. You understand, because just like the Conrad Murray's case in the United States, when he administered an anesthetic drug to Michael Jackson, Propofol, in a non-hospital environment, he was convicted. I think we must begin to move from this clear medical negligence to a realm of section where Section 51 of the Criminal Offences Act becomes applicable. Because in that instance, if there is a clear reckless disregard for human life, you can be charged for manslaughter. You understand? I think we need to, because you see, we have overlooked some of these things. Yeah. We were here when a human being was sent to a hospital, and according to the hospital authorities, there were no family member, and the person was not paying the bills. They loaded a human being in an ambulance and discharged a woman in the bush. The woman lied there and died. What is the current state of that? And the media, you are not following. You understand? Okay. I think
this is not our problem.
We must also begin to push.
You have blamed us twice already.
We must begin to push some of these things. You see, and some of these, you see, people are actively talking about some of these things. In all these instances, it might not be as we might want to put it, but because of the underlying factors and situation that has happened, people will pour their frustration. And one thing is that when you are at the hospital and you fail to do one thing, the person you are attending to may have thousands of voices because they have family members. They will go and amplify, but you at the hospital may not even have that particular chance. So I think we must not crucify the system. We must work hand in hand just to ensure that we put up a system for our own sake.
Let's expand the conversation and bring in the president of the Emergency Medicine Society of Ghana, Dr. Daniel Osei. He's joining on Zoom. Dr. Nanaba Adoma Dawson Amoa is a specialist at the Emergency Medicine Society of Ghana. She's joining me here in the studio. And also on Zoom is the chairman of the Health Committee of Parliament, Dr. Mark Ket Nawani. Gentlemen and lady, thank you very much for your time this afternoon. I want to begin on Zoom with you. From the president of the Emergency Medicine Society of Ghana. Really, why are you making this call that there seems to be a blame attributed to the health officials, and rather the blame is not much being given to the systemic failures which caused this?
And so this position is being advocated because we've realized that we are overlooking the systemic-wide issues and just focusing on the end point of the care, where unfortunately some of our colleagues had to make decisions based on the screening system and based on the logistical challenges to mitigate the effect of the system. Unfortunately, whatever decision they came up with doesn't sit well with most people or many of us. And because of that, it looks like our attention has been shifted from the systemic-wide issues, and now we are only concentrating on just the endpoint decision. The question is, if we continue to emphasize on this decision, where will our system be in the next 1 week, in the next 2 weeks, in the next 1 year? Who will be the next Charles Emisa? And that is the question we need to ask ourselves. That's why we are saying that let's broaden the scope. Let's look at all the root causes and let's address them.
Dr. Osai Kwame, I'll come back to you, but let me come into the studio and speak to Dr. Dawson Amoah. What systemic failures do you think contributed to the death of Emisa Charles that people are refusing to acknowledge?
So, first of all, thank you very much for this opportunity for both myself and Dr. Osai Kwame, on behalf of MSOC, to come and weigh in on everything that's been going on. Like we mentioned, or like I mentioned to you, I think there's been a lot of discourse, and part of it is challenging for us because the discourse is being driven by people who are not necessarily facing the systemic challenges on a daily basis. One of the biggest problems that we have as a nation is, one, we do not value healthcare. And it's seen every year or every 4 years, every election cycle, when there's a lot of noise, a lot of promises made, and it seems like healthcare always features relatively low on the list of promises. More especially emergency medicine or emergency healthcare in general. There are several problems that we face as a country. One, yes, we have amazing ambulances. Do our ambulance staff have the requisite training and the retraining that they need to be able to offer care when they have it? Amazing systems. If you look on paper, the National Ambulance Service is very well designed. They have amazing plans in place, but are they always followed? And are they always given the support that they need to follow these all the way through? Going back to Mr. Emisa's unfortunate case, it's disappointing that at the time that he was picked up, he had to be moved to different facilities in an attempt to get care. Following procedure, what could have and should have happened if we had, for example, a centralized system, is that the ambulance crew could radio back and find out from the centralized system, where do we have a bed available for this patient? Keeping in mind that when we talk about no beds, it's not just about a physical bed, it's also about the resources that are needed to treat the patients. It's also about the healthcare staff that are needed to treat the patients. It's also about the financing. Again, healthcare financing here in Ghana, particularly with regards to the emergency system, is one of the weakest. For example, I'm sure you didn't know that every time you pay for your vehicle registration, a percentage of the money is supposed to be sent to the National Ambulance Service to help finance their activities. I'm not sure how often that happens.
So there's the law is there, but it's not implemented, that's what you say?
I do not know if it is being implemented. I did a study in 2018, and as at the time, it wasn't really being carried out. So the ambulance service is handcuffed because then they do not have access to the finances that they need. There's a policy that says that people are supposed to receive emergency care for the first 24 to 48 hours without asking for money up front. Nobody goes further to ask who pays for that care then. Nobody is talking about things like, does the National Health Insurance Authority reimburse facilities in time for them to have the logistics, the things that they need to be able to provide this emergency health care? So that's why we are particularly concerned as a society, because right now everything is about the few people whose names have been dismally published in the media, and nobody's talking about how we are going to solve these problems. In the next 5 years, 6 years, it could be any one of us. And it's really disappointing when we see our politicians pushing the narrative of punishing individuals because they are the ones with the power and the authority to make the system better. So rather than focus on individuals, we as a society would really want them to focus on how do we improve the system, move forward, and make sure that this does not happen again.
I'll come back to you. Let me go on to Zoom again and speak to Dr. Ket Nawani. He's the chairman of the Health Committee in Parliament. Grateful for your time this afternoon. Already there's been a lot of concerns raised by health professionals, including the ones we just heard. As the chairman of Public or Parliament's Health Committee, do you agree with these concerns that have been raised by the Emergency Society of Ghana? Hello, Dr. Nawani, can you hear me? Dr. Nawani, are you there? We're still trying to connect with Dr. Ket Nawani. He is the chairman of Parliament's Health Committee. Let's continue the conversation. Dr. Osei Kwame is also the president of the Emergency Society of Ghana. He's on Zoom with us. Dr. Osei Kwame, so does MSOG believe any individual healthcare workers should be sanctioned in this case?
And so we've also perused the document, and we've also gone behind, and we've also been informed of certain things that happen. If the finding of MDC is said that any of our people are found culpable, we believe in accountability. We are not shielding away from accountability, and if that be the case, we believe they should go through the system, but in a measured kind of approach. But we are emphasizing the fact that everything and every decision that was made, imagine a patient being sent to a hospital, goes to the first one, is diverted to a second and a third. Definitely, it can't just be a case of attitudinal issue or the fact that some people were not willing to take up. It speaks of a systemic issue, and that is where we want us to address all the issues from, because it is not only the fact that they were stressed or they were outnumbered, overwhelmed, but in terms of coordination, who is supposed to make calls when it comes to coordination? Who is the person in charge? Why are people's names not being mentioned? Why are certain institutions who have neglected certain decisions all these years, why are they made to go scot-free and only 7 people are being scapegoated? That is what we are saying, that if we really need to, it doesn't matter who is at fault, that person needs to face the rigors of the law. But beyond that, are there other people? Are there other institutions? Are there other factors that we need to examine in the context of this unfortunate death? We think there are many people and many institutions. If we dare to say all the way from the top of the health system, people need to be accountable for everything that is happening in terms of straining our emergency medical systems. Everything that needs to be done, we need to start from the top. Let everybody be accountable for whatever decisions or indecisions on their part for all this work. There are so many questions that MSOG wants to ask. But the question is, at the end of the day, if we don't allow the system to be scrutinized, then where will we be in the next few months? We will still come back and be debating this, discussing this. The narrative will not change.
What reforms, Dr. Dawson, do you want government to embark upon to address this issue of no-bed syndrome?
So first of all, one thing that we, or personally, the Emergency Medicine Society of Ghana thinks that we should focus on is shifting the narrative of just saying no bed syndrome. Because when you, for example, engage on social media, there's a lot of interesting comments. Some say we can get bunk beds and put them in the emergency to attend to patients. Somebody suggested they can bring mattresses from the house. And when you are practicing, I mean, I've had instances where somebody suggests, oh, what about the bed that I will sleep on? I should give them that bed, and then they attend to the patients on that bed. We've coined the term no bed syndrome, and it's sort of, we are sort of regretting it because it's shifting focus. We are not only speaking about physical beds, but we are talking about capacity. So when we talk about no bed syndrome, we not only mean the physical bed, we mean flow through the emergency, flow through the hospital. So we do not want people coming into the emergency and spending 3 days, 4 days in the emergency. They need to be able to move on to their final points of care. One of the major things that would help them do that is if we are able to arrive at a diagnosis in a timely fashion. For that to happen, we need to be able to put in diagnostic services. So we need to be able to do our lab investigations and get the results on time. We need to be able to do imaging studies, so CT scans, X-rays, MRIs, etc. We need to be able to do those and also get the results back on time to give us an idea of exactly what is wrong with the patient. In the ideal setting, the emergency care, we are dealing with the person who walks in, I'm sick, I'm injured, and I don't know exactly what is wrong with me. The task then falls to us to figure out what is wrong with you, stabilize you and provide that immediate life-threatening or limb-threatening treatment, and then pass you on to the team that is supposed to continue care where applicable. If we cannot make the diagnosis in time, because for a variety of reasons, patients' relatives have to go and pay for lab samples before they are even given the bottle, before the sample is taken, that adds another 2 days to your hospital stay in the emergency. That's 2 days that we cannot admit somebody else from outside onto that bed. So what we would really love for governments is to streamline the process. Let's get people moving out of the emergency by making sure that other services, such as labs, such as imaging, everything else is on point, we are getting them within time. There are standard benchmarks, and I love the fact that Dr. Sampani mentioned that the World Health Association mentioned this. There are standard benchmarks, and it is not only for doctors, for lab technicians, for radiographers, for radiologists, across the hospital. Unfortunately, patients come, and as doctors and as nurses, we are the front faces. So we are the ones who bear the brunt of everybody's ire, everybody's frustration and anger, but it is not dependent solely on us. There's very little I can do about the fact that your lab results are not in, so I still don't have an idea whether you need to be transfused or not. I do not have blood for you because people are not donating blood often to the blood service, so I cannot give you a transfusion, so I cannot discharge you or send you home. Then you occupy that bed, and then somebody else cannot move in. So what we need for government to help us do is streamline the process of moving patients out of the departments, out of the emergencies, so we can admit new patients by improving the healthcare financing, making it such that people do not necessarily have to carry cash to be able to access emergency care. It's one of the most heartbreaking things as a healthcare professional. When you are stuck there, you know what the person needs, but you simply cannot give it to them because of lack of funds at that point in time. And it may happen to anybody. It's not that you do not have millions in the bank, but you do not walk around, well, I do not walk around carrying $1 million Ghana cedis in my pocket. So if I need $1 million Ghana cedis at that point in time, does that mean I should also die? And that responsibility comes or rests solely on the government and not the doctor, not the nurse.
I understand we have Dr. Ket Nawani back on the line. He's the chairman of Parliament's Health Committee. Dr. Nawani, I want you to respond if you can hear me. Unfortunately, we have lost him on the line, but we're still trying to reconnect with him to get back to us and answer a few questions that are being raised by the Emergency Medicine Society of Ghana. And their president, Dr. Osei Kwame, is also on Zoom with us right now. Dr. Osei Kwame, many are asking, why is EMSOG concerned about the publication of the names of health workers involved in this?
So on two fronts. EMSOG strongly believes that until they are found culpable, they are still being investigated. And as of now, they've not been found culpable. We still firmly believe that the committee was mandated to go on a fact-finding mission. And because of that, their mandate didn't extend to pronouncing culpability on any of these members of our society. So we think that going beyond that mandate puts them at risk. Their mental health is at risk. Beyond the mental health, anything can happen to any one of them. On social media, they are being cyberbullied. Everywhere you pass, there is a statement here, there, that affects them. And we believe that until, for example, the question is what happens if there are various institutions, whether MDC or NMC comes out, and then after their investigation, they say that, well, they didn't find much to do with disciplinary action. And that's the reason why we stand against the fact that there should be a public declaration of their names. And you go to social media, other people are even asking for their faces on TV as well as billboards just to be able to meet out their frustrations on them. We don't think it protects them as much as it doesn't protect them. It also has adverse effects on the workforce remaining. Most people are asking themselves questions as to all the time that they bend their backs just to go around the system and see every patient, and make sure that people are living. What happens to them now? Is their colleague next time? It could be them. And it's not because of a willful individual negligence, medical negligence, but this is born on the back of systemic inadequacies. Our system, our emergency medical system, our emergency health system is strained, and nobody can run away from that. It is highly strained. The tension is breaking. And if we don't take care to address the root causes of all these ones, it will get to the personnel, and we don't want it to get to the personnel, not in terms of bringing down their morale per se, but in terms of the productivity, the efficiency that they will be offering in their various hospitals. We don't want them to be affected negatively. We want them to continue doing the work that they love doing and helping Mother Ghana to be healthy.
Right. I understand we have back on the line Dr. Market Nawani. I want you to respond to me if you are on the line, Dr. Nawani. Do I have you?
Yes.
Oh, thank goodness. Welcome to the show. We're having the conversation with the Emergency Medicine Society of Ghana, who are saying that it wasn't right to have published the names of the health professionals who were implicated in this issue, and that the real issue that should be tackled are systemic failures. Do you agree with them?
First, let me say good afternoon to the viewers of your TV station and say that we first must acknowledge the good work that the committee has done. As my good senior, Dr. Nsiasare, said earlier, there have been occasions in the past where somebody or some individual had died because of this no-birth syndrome and the movement from one hospital to the other. I believe committees were set up, investigations were done, but what happened? Apart from the facilities that were mentioned, 7 of them, that ended it. And today, we are faced with the same problem of that simple explanation of no-birth syndrome being given for the cause of death of the late Charles Temita. So unless we change the ways we do things, it will continue to be the same thing. As we speak, the no-birth syndrome has been used to explain the death of a pregnant woman at Kaswa Children and Mothers Hospital. A mother who was admitted for 36 hours, and when it came to the time that they should do a cesarean section, the explanation was that there was no bed in the recovery ward. And I asked myself, why do we have to always look for politicians to blame? Why do we always have to look for systemic problems? Problems that when you get a particular case, I don't think that when you get a particular case, like that of Charles Emisa, who came in with bleeding from the arm, a cut, a deep cut from the arm, do you think of building new hospitals? Do you think of providing equipment at that particular time? Do you think of recruiting more healthcare personnel, etc., to do the work? Let's look at ourselves as professionals and know that, yes, the system failed the late Temita, but the system is operated by people, and decisions had to be taken. And the decisions did not favor the late Temita.
Right. Point well noted. But the concerns are really that these most of these facilities are ill-equipped. For example, Dr. Dawson raised the concern about the quota of money allocated for the Ghana ambulance anytime somebody renews their license, correct? And she says that per her last check, those monies are not going to the ambulance service to well equip them. So you are in a position of power. You are the chairman of Parliament's Health Committee. What sort of implementation policies or enforcement policies are you ensuring that some of these policies that are already in place are enforced and really the monies go to the ambulance services so that they are well equipped enough to tackle such issues when they come?
As politicians and as people who influence policy, we have a lot of work to do, especially with the limited resources that the country has. I'm not speaking for anybody, but as a chairman of the health committee, I sit on the NHIA formula, for example. We try to increase the allocation for the ambulance service so that people don't have to pay for ambulance service. But like any other sector, the road, the agri, the education sector, etc., that cannot meet all its ends. The same thing applies to the health sector. And we'll continue to fight through the conditions. But let's take them case by case. If this person was a brother, a sister, a daughter of any of those who are working there in the night, would this be the best decision to take? Look, we have had instances where at the accident scene, when lying there bleeding and the person is still alive, and you are a medical professional, and you go and meet such a situation, you've got to help. You've got to help. There's no way that an accident will occur on the road, and you go and meet the person still being alive, and you will not do anything about it. How much more an individual who was sent bleeding externally, bleeding out of a wound, and the first hospital turned away. The second hospital did not do anything. The third hospital turned away and they refused to go, and for 70 minutes, this patient was not attended to. Let us be very, very frank. The committee has done its work. Let us appreciate the work that the committee has done. That is not the end of it. The Minister of Health has said that he is not going to cover anybody who is implicated in this or any facility that is implicated in this. In view of that, he has referred the case to the regulatory authorities, the Medical and Dental Council, the Nurses and Midwifery Council, and of course, the employers. And one of your commentators said that why did the committee probably not mention other players? I believe that the investigation, that is not the end. What the lawyers will say that the investigation came out that there are some people who have got a prima facie case to answer or some questions to answer. And those people have been noted. If they go further and they think other people have to come in, I believe that it will take place. But let us appreciate the work of the committee. For the first time, a committee that was set up has come out comprehensively that no, let us not verify the Nobel syndrome. It is, and I'm going to document it. We set up the committee, let us respect their findings. We can criticize them, yes, but let us respect their findings and build on their findings to create a proper health ecosystem that can stand the test of time.
Right. Dr. Nawani, the Emergency Medicine Society of Ghana, the Ghana Medical Association, and other health unions are saying that they are not against punishing these doctors and nurses. What they are against and think are being scapegoated is the fact that these doctors and nurses' names have been put out. They say that it is having a mental toll on their health. It's affecting their mental health, and they are wondering why that became necessary by the committee to do. Those are the concerns that they are raising. Yes, they deserve to be punished for whatever crime the committee finds them to have done, but publishing their names has put them in harm's way.
It is very unfortunate that their name has been mentioned, but so many committees have been set up anyway in this country to investigate so many things, cases of corruption, etc., cases of murder, etc., and people's names come out. Probably we have to look at, if we want to look at this issue in that way, then holistically we should look at it, because whenever somebody is named as corrupt, he's also exposed to public ridicule, he's exposed to the social media and those things. So let us look at it. But from history, from previous encounters, where only facilities were mentioned, we did not get any results. The investigation did not go anywhere, and we did not hear anything. Nothing happened, and we were back to square one.
Okay.
And so probably the committee might have thought that they needed to go in a different direction. I'm not defending the committee's decision to bring out the name, but I'm saying that probably as a country, we need to look at this thing holistically.
Okay. Dr. Nawani, don't go yet. Dr. Dawson Amwa is still in the studio with me. I want to believe that you have a few responses to the chairman of the Health Committee, but let me ask my question, and if you have a response to that, you can give it. What do you expect the Ministry of Health and the Ghana Health Service to do to ensure that what happened to Charles Emisa does not recur? And if you want to respond to the chairman also, you can begin with that and then answer my question effectively.
Thank you very much for the question. I think one of the things that I am particularly passionate about or looking forward to is working in a system where you are not actively fighting the system every day. You go to work and it feels as though you, the doctor, are trying to do the work of the counselor, the social worker, the politician, in addition to the medicine that you are practicing. So what I would love for our mother bodies, the Ministry of Health, the Ghana Health Service, the Health Committee in Parliament, is to sit down and dispassionately look at the system, look at everything that happens. Do we have enough healthcare workers in Ghana? How many people are leaving the country on a weekly basis? How many doctors are leaving? How many nurses are leaving? Because working here is stressful. There have been a few comments passed about, if you are tired, resign. If you don't want to work, leave the country. I wonder what would happen if many of us healthcare workers, particularly those of us in the emergency, took that to heart. When the world was going through the COVID pandemic, we saw what was happening in the Western countries. We were speaking with colleagues from the US, the UK, and they will talk about how they are burnt out and how they are tired. The situations that they are working under are so stressful. And those of us in Ghana here were like, wait, you're describing a regular Tuesday for us. We work under these stressful conditions that we did not help to create, that we do our best to try and help patients through. A colleague of mine paid for a life-saving drug for a patient, 18,000 Ghana cedis. This was about 4 years ago. He paid out of pocket because there's no other way this person would have gotten that medication. We need help. We cannot do it alone. We cannot solve the problems of financing. We cannot solve the problems of staffing. We cannot solve the problems of flow. For example, if a woman delivers and is discharged from the hospital from our side medically, but has not been able to settle her bills for whatever reason, We cannot throw her out onto the streets. So she stays in hospital on the bed. Then somebody who needs to move from the recovery ward to the ward cannot move because there's somebody who is occupying that bed. Somebody cannot move to the theater bed, from the theater bed to the recovery ward because that bed is also occupied. So these are the help. This is the help that we need and we expect from the people who have this power. Individual scapegoating is dangerous for several reasons because, as we've seen in the past few days, the narrative has shifted. The focus has shifted entirely from the systemic problems to individual names. People are receiving threats. They are scared to leave their houses for fear of what they would face. And it's showing up in work as well. We need the support of the people who have the power, who have the purchasing power, the political power, to be able to make the changes that we need. How can we retain more healthcare staff in the country? Not just doctors, not just nurses. We need more mid-lab scientists. We need more porters and orderlies who can help us with the movements of patients, with the cleaning of beds, etc. The hospital is a beautiful ecosystem, and we all work together as one. But if the people who are supposed to provide for us, who are supposed to keep us united and in check and well put together, do not recognize that this is the system that we are struggling under, it is not going to get better. And it is almost impossible to say that if 7 hospitals 5 years ago and 3 hospitals now were not able to do something, it is the individual's fault. Obviously, it's a systemic problem, and we need help solving that. We cannot just put blame on some people and expect everything else to work out.
I'll come back to you. Dr. Osei Kwame is the president of the Emergency Medicine Society of Ghana. He's joining us on Zoom to contribute to this conversation. Dr. Osei Kwame, does MSOG believe Ghana's ambulance and referral systems are fit for purpose, you say?
In terms of the quality of the vehicles for the ambulance, we believe they are up, there with the rest. But in terms of the quality of education, the skills required, Ghana operates a system. Our EMTs, basically, we have the basic EMTs, we have the advanced EMTs, and we have paramedics. Right? A lot of our personnel manning the ambulances are either basic or advanced. We have very few paramedics here. And these paramedics have been trained to a certain level that they can make certain interventions that are, probably equivalent to some of the things that we do in the hospital, but not the basic level. However, that is not to shift blame from anything that was found by the committee. We also believe that the committee did a very good work. We just have issues with some few of declarations that they made, and that is what we talk about. In terms of our referral system, I want to ask the ministry why, as of now, the reviewed referral system is not yet being implemented. Because for some years now, we've gone through it tediously, we've reviewed it, and to some extent, who knows, maybe if the referral policy was implemented, this wouldn't have happened. I'm not saying that definitely it wouldn't have happened, but we looked through the referral system, we decided to go through every bottleneck in the referral system, bridge it, make sure that it's adaptable, and make sure that it is convenient for the current situation and addresses the challenges of the current situation. But for so many months now, years, nobody has heard of it. It's probably sitting somewhere waiting for a decision to be made on. And that is why we are saying that when we begin to look at it in a fractionated manner, where we look at only the people who made decisions, right? Decisions born from systemic failures or systemic inadequacies or inefficiencies, then we stand not to benefit as a country, because every single bottleneck should be holistically addressed. Yes, it may be that we may not be able to invest in a capital-intensive hospital now, but there should be a plan. There should be a holistic approach where we draw out plans, strategic plans for the next 5 years or the next 10 years. This is what we are doing. This is how we are getting there, and everybody has to follow this plan. With such a plan in place, we should be able to mitigate majority of the issues that brings about the no-bed syndrome. Other than that, we'll continue moving around and then in circles, trying to blame people. The point is, a referral policy irrespective of how bad it is, it's at least a scheme work for us to ride on and initiate a very good flow for emergency system.
Okay.
If these people had been able to call, if there was a command system where they would have been directed or redirected appropriately to the next facility which has space, who knows, Charles may be still with us and we will not be having this conversation. That is why it is important that we roll the reviewed referral policy as quick as possible, and then we also take a look holistically at, the Honorable was saying, we take a look holistically at the whole system and not conveniently blaming the end users of the system.
Dr. Ket Nawani, I want to believe you're still with me. Do I have Dr. Nawani with me?
Yes.
Right. You've been listening to the health professionals. They have been raising concerns and also posing some questions. Of course, like I mentioned earlier, they are saying that who is to blame has to be blamed, but could be done without name calling. As the chairman of the health committee, you also work closely with the minister in charge of that sector, Kwabena Minta Akano. What sort of reforms do you think you can propose to the minister to overhaul the health sector so that we do not witness what occurred, the unfortunate incident that led to the loss of Charles Emisa's life?
Well, as somebody who has been part of the system for 33 years, I've practiced as a doctor, 25 years in private practice. I believe that Ghana will have improved generally from the time in 1993 that I was at Kolebu teaching hospital as a health officer, then to Cape Coast, then to Dunkau, and a lot of local appointments here and there. There have been improvements, but we still need to do more. And I've been attending international conferences on behalf of the country, Ghana. And I must say that Ghana is comparable to most African countries that are doing well. I'm talking of Kenya, probably South Africa, Angola, and these days Zambia and other countries are all catching up with us. We need to fix the economy, and when we fix the economy, we also need to fix the health center, the health care system. As we speak now, the minister, Honorable Akando, has agreed that there must be an electronic management of beds. In other words, we shouldn't go to a facility and the facility will say that there's no bed. There should be a computer system, an integrated management information system that will manage the beds such that if there are beds in Kolebu, it is already known. You don't need to go there and somebody will tell you they'll go away because there's no bed. Or to go to Rich and they say that the beds are full. In other words, the human factor in the management of beds will go away and will give this thing to the digital system. Apart from that, we've been speaking about the emergency fund, creating some form of an emergency fund that will take care of the patient for at least 24 hours. Whether you have money or not, that emergency fund should take care of you. All these are in the pipeline for this thing. And the other aspect is that, honestly speaking, the human factor is very, very important. I'm not saying that we can remunerate our health staff like in any developed country, but probably we need to look at that aspect very well and see to what extent we can attract more people to the health sector or more workers to the health sector, and also prevent the migration of health workers to other countries. I know somebody saying that, yes, I asked them to resign and all those sort of things. Yes, I was a bit harsh. And I believe that probably that is not actually what I meant, that people should leave their work after training for 10 good years. To be an emergency specialist, for example, you've got to go to a medical school for 6 years, and then 3-4 years, you've got to use it to be trained as a specialist. And that is about 10 years of training. But let us be humane.
Right.
Let us try to work hard. Whatever decisions we take, let us consider that person as our daughter, our brother, our sister, our father, and see whether we can be better human beings. We need an introspection of ourselves as medical professionals. I'm one, and I know that how it feels. The turnout and everything, I understand it perfectly.
Okay. Dr. Ket Nawani, he's the chairman of Parliament's Health Committee. Thank you very much. I still have Dr. Dawson Amoah in the studio with me. She's with the Emergency Medicine Society of Ghana.
Yes.
And the association's president, Dr. Osei Kwame, is also on Zoom with me. I want to pick your final words, both of you. I'll start with the lady, obviously. In a minute, please give me your final word.
I'm very glad to hear the Health Committee's points that there's plans to finally operationalize things such as the Emergency Care Fund, such as improving remuneration and attractiveness of the healthcare system so that we can get more people in there to reduce the workload and reduce the benefits or the effects that those of us who are already in the system are facing. And I am also really glad to hear that he does admit that his comments were quite harsh, and we hope that moving forward, we do not fall back into this antagonistic view. We are all working together. We want to make sure that every Ghanaian is safe, every Ghanaian is able to access high-quality healthcare when they need it without having to worry about what it's going to cost at that point in time, without worrying about who they are going to meet, etc. So we believe that we are all working together to this common end, and we hope that we can come to one common table instead of seeing each other as adversaries across the table.
Dr. Osei Kwame, your final words.
The association's condolences to the family of Charles Emisa. We are with them. Matilda is one of us, and then we want to really let her know that we support her and we are with her as well as with the 7 who have been mentioned. We want to end on the note that we are asking the Minister of Health to engage in a broader stakeholder participation in terms of how to get to the root of this no-bed syndrome and the factors that are mitigating the acceptance of patients on the various wards at various hospitals. We really are asking for expert opinion. We know most people ask and talk about being present, but we need the presence of emergency practitioners to be on each stakeholder platforms or committees so that they will be able to inform the government appropriately as to what to do to curb it in the back. Secondly, we are asking the government that we should, as much as possible, implement or roll out the new referral policy. It's going to address a lot of these challenges that have been already identified, and we believe it's not going to fully solve it, but it's going to go a long way to solve it. Let's roll the new policy out. The new referral policy is a must.
Right. Dr. Daniel Osei Kwame, thank you very much. He's the president of the Emergency Medicine Society of Ghana. Dr. Nanaba Adoma Dawson Amoah is a specialist with the Emergency Medicine Society of Ghana. Thank you very much for joining the conversation. And earlier, we heard from Dr. Ket Nawani, who is the chairman of Parliament's Health Committee, also joining us via telephone. In other stories this afternoon, residents in parts of eastern Accra should prepare for continued water supply interruptions as Ghana Water Limited attributes the situation to damaged pipelines, aging infrastructure and illegal connections which are disrupting supply and reducing water pressure in several communities. Managing Director of Ghana Water Limited, Adam Matawakilu, together with his management team, says the situation is being addressed through ongoing inspections and rehabilitation works on key transmission systems as part of efforts to stabilize the supply. The following report has more.
Toll by the Ghana Water Limited, according to them, forms part of efforts to assess critical infrastructure within the urban water supply system and also update the public on interventions being taken to improve reliable water supply across the country, especially within the eastern parts of the Greater Accra region. Now, according to the managing director, key issues they identify hindering reliable water supply include the physical leakages and also illegal connections by some individuals. A situation, he says, is hindering the supply of water to some parts of the Greater Accra region.
One is stealing, theft, and one is physical leakage. So in August 2025, we started with what we call the Revenue Enhancement Team. And this team, there were 3, and it was yielding some resource. So in January, we increased it to 10, and currently they are working. And by the end of last year, we reduced the non-revenue water to 51.6, which is an improvement, but it is not significant. We also did an investigation on the fiscal leakage and realized that the 3 lines from Pong to Temabusta is where we have issues. Because when we take the regional land revenue water, there are 2 regions that we have very high, Tema and Accra West. So investigation was done, and we realized that the main transmission line, which is one of them, which is the metal one, is 21-inch transmission line, has a lot of leakages.
The managing director of Ghana Water Limited, Adam Matawakilu, also urged individuals to dismiss claims that the Ghana Water Limited is moving away from its core mandate, insisting that they remain fully focused on efficient water production.
Last 2 weeks, I read in the news where we're told that Ghana Water Limited is drifting from its core mandate. I want to assure Ghanaians, we are on course to achieving our core mandate of providing potable water to the people, the urban communities of water of Ghana. Anyone who thinks that we are diverting should provide evidence. Having a subsidiary doesn't necessarily mean you are diverting from your core mandate.
Ghana Water Limited says intensified rehabilitation works and efforts to curb illegal connection are expected to improve water supply to affected communities by the end of the year. Reporting for Joy News, Ramat Bashiru, Central Workshops, Ghana Water Limited.
The Volta River Authority, VRA, has raised concerns over the increasing incidence of illegal sand mining along the downstream of the Volta River. According to VRA, this activity could lead to environmental degradation and worsen flooding effects on the river banks. Fred Kwame Asare reports that the authority discussed this during an emergency preparedness plan and environmental management workshop in Ho in the Volta region.
Sand mining activities are rapidly expanding along the lower Volta basin, stretching from the Akosombo Dam to the Gulf of Guinea. In the Volta region, these activities have become a means of livelihood for residents in the central, north and south Torn districts, among others. Addison Doji Monyu is the Central Torn District Chief Executive.
From Fedebo heading to Zulu, some years past, that was when they were mining the sand. And they did it to the extent that electricity poles were not even spared. Some of the electricity poles are now bending. It took the assembly a hell of time before they were stopped. So, fact to be told, the activities of these people is not the best for us.
The Volta River Authority warns that areas where these activities are widespread and unregulated are at greater risk of flooding.
They are also even filling the water, creating trackway or a more travelable way inside the water so that the trucks can access the sand right in the middle of the water. If you do that, you're changing the morphology of the river. So you're expecting it to be in the channel, but with just a little spill, it spreads. And then you have, and there are very low-lying areas in these communities. So you would have people having their places flooded. So
the Director of Water Resources and Renewable Energy of the VRA, Engineer Abdul Nur Wahab, called on stakeholders to work together with his organization to curb these activities along the Volta Basin.
Illegal sand mining and then people, occupying the wetlands. What happens is that it changes the land topography. And as a result, you realize that when there is a need for a controlled spillage, or even when there is high rainfall, places that originally shouldn't have gotten flooded gets flooded. So that is a concern that we have as far as those activities are concerned. The idea is, as part of this engagement and this stakeholder engagement, the expectation is together we should find a way of addressing it. The assemblies should enforce the laws and ensure that even if there should be sand mining, there are ways that it has to be done properly. It should be done in the manner that is acceptable, but not in an unacceptable manner.
There was also a call for the assemblies to ensure structures are not built in wetland areas to help reduce the impacts of flooding along the Volta Basin. Fred Kwame Asari, JoyNews.
Let's talk education, because the 2026 Basic Education Certificate Examination BEC officially ended on Friday, but attention is already shifting to the ongoing WASI, where some candidates are currently undertaking practical papers ahead of the main written exams. The English language oral paper is also scheduled to take place on Wednesday. To help us understand the latest developments, we've been joined by the Head of Public Affairs at WAEC, John Kapi. Mr. Kapi, welcome to the program. You told me when I spoke to you at the start of this exam that at least 7 persons had been arrested for exam malpractices during the Basic Education Certificate examination. After it ended, can you give us an assessment? How many people were so far arrested for exam malpractices during the BECE?
Thanks very much for having me. Good afternoon to your viewers. As we speak, we have effected about 43 arrests, a number of, and all of them are teachers.
Those students arrested this time?
Well, usually students are not put under arrest. Their statements are taken, and then these are brought back to the office for further investigation before a final decision is taken about them.
When you were going round last week, I saw you, catch some twins exchanging paper, writing for each other, and other persons also were caught in the act as well. Overall, how many malpractice incidents were recorded across the centers?
For now, it will be difficult to tell because although the depot keepers or the inspectors are able to transmit these, reports on a daily basis, we have not sat down to look at the number of them. There are some of them that we may have to discard for want of very good evidence, credible evidence for that matter. So I would say that for now it will be difficult for us to tell until we are done with the marking and then we are ready to release the results.
And what's your overall assessment of the BECE?
Generally, I would say that things went well. All the candidates who registered for the examination had the opportunity to write. Examination materials were available to every single candidate who registered. Even though we had some teething problems with, distribution on the first day, I think on subsequent days, the examinations went well. So I would say that generally we had a good examination period.
We unfortunately recorded an incident of the death of a student in the Upper West region. Did we record further deaths?
No, apart from the incident that occurred in the Upper West region, we did not have any other unfortunate incidents of death or any such thing.
Let's look ahead to the WASI. How are preparations so far? We know that some of them have already begun practicals.
Well, I think that just like the BEC, we are very well prepared for the WAS as well. Some practical papers have been written. Some other papers, like cost accounting, has also been written. Because of the numbers, especially coinciding with the BEC, we gave priority to the BEC. So now for this week, on Wednesday, as you earlier mentioned, the oral English is going to take place. And then as the weeks go by, we get into full throttle.
We usually hear about supervisors, invigilators complain about their monies and funds not being released by government when it's approaching the exam period like this. How is the situation like?
Well, this time around, I would say that we would not have any challenges with funds. We have, usually when we submit, well, our budget is normally submitted in October of the preceding year. So by the time examinations begin, we ask for part of the money that will enable us to do our pre-examination activities, conduct the examination, and then get ready for marking. When it's time for marking, we'll write for the rest of the money, and that is paid to us. Sometimes the money comes in before we even finish with the examination. So as we speak, I would not have any challenges with money, and so we'll be able to settle all our indebtedness as far as our supervisors and invigilators are concerned, and also be able to pay all our examiners when their job is done.
John Kapi, thank you very much. He's the head of public affairs with WAEC. Still on education, though, the Garden City University has broken ground for Ashanti Region's first private university teaching hospital. The 100-bed teaching hospital project, sited at Kwabre, Kenyase campus in the Ashanti region, will be the first by a private university in Ghana. The hospital, expected to be completed within 18 months, aims to strengthen practical training for health professionals and expand access to quality health care for people in the Ashanti region.
With a current student population of approximately 14,000, Garden City University maintains a strong emphasis on business and health sciences. Management disclosed the development during a courtesy call on the Asantehene Otumfuo Osei-Tutu II at the Menchia Palace in Kumasi. The visit also served as an official introduction of the newly constituted 21-member University Council and the new Vice-Chancellor, Professor Eric Kwesi Ofori, a specialist in medical imaging who assumed office on March 2nd, 2026. Chairman of the new council, Professor Ellis Owusu-Dabo, who led the delegation, explained the university's deepening commitment to health sciences as it enters its 26th year of operation.
To contribute to the growing need, within the health sector. Government alone cannot do this all, So we're a private university. The idea is to train more, reduce the deficit in terms of the health, human resources for this country. And as you're aware, we are very much focused on health, nursing, midwifery, and several other physician assistantships. And now we're moving into, the graduate entry medical program, which eventually should see many doctors being trained by this private university through our teaching hospital. The idea is to reduce the deficit and help give, several youth employment opportunities and help contribute to the national economy and the development of this country.
The delegation also congratulated the Asantehene on her 76th birthday and expressed gratitude for the monarch's long-standing support, which contributed to the university receiving its presidential charter in June 2024, granting it full university status. Professor Ofori noted that plans are underway to launch a graduate entry medical program and a graduate entry dental program. The university is simultaneously advancing other major physical infrastructure projects, including an international student and faculty hostel, a nursing and midwifery block complex, and a multi-purpose examination block complex.
Otumfor was so gracious to us, having been originator of the university, he knows how the university started and so forth, and he was so much impressed about the caliber of people that formed the council now, and he was looking forward to the growth of the institution in the near future, medical school. So these are some of the things that are happening there. So the medical school program and other health-related programs, we want to strengthen it, and with the teaching hospital coming on board, we hope that it will really go a long way in helping us in the training.
Otumfor Osei-Tutu II thanked the university officials for the honor done him, charging the new vice-chancellor and the council to protect the integrity of the institution.
For decades, students and staff at Sunyani Senior High School have relied on nothing more than a small sick bay for medical emergencies. Well, that story changed today when the 1999 year group broke the ground for a fully fledged clinic on campus to address frustrating night referrals. Anna Sabet has more.
The Sunyani Senior High School campus is buzzing with a new sense of hope, not for academic laurels, but for healthcare. The 1999 year group has officially broken ground for a fully fledged clinic. For a school of this size, the current sick bay has long been a challenge, often serving as a temporary stop before the dreaded night referral to town. Headmaster of the school, Gordon Osei-Mafo, says conveying 6 students in the night to the outside hospital for years posed several problems for the school.
Because we're not having a clinic in the school, most of the students will just fake illness in order to get easier to go out. So without the clinic, it also brings out indiscipline. And apart from that, to convey some students in the night to the outside hospital or clinic also poses a problem for the school. Because at times, there will be breakdown of vehicles. A vehicle may not be around at that time. But now that the clinic is in the school, all this is going to help us.
Leading the charge is the group's president, Eric Ajay, who says this project is about repaying a debt to the school that built their character. He's not keeping the vision small.
This project was born out of a passion to help the school that shaped us into who we are today. We, the 1910 year group, conceived the idea, but we are calling on all other year groups from the 1980 to the current year to come and support us so that we can achieve this the success of the project.
The ceremony had royal backing. The paramount chief of Sunyani, Odifo Ojiamansan Bwahin Koko II, described the project as long overdue for a city that has benefited so much from SUSEC. Showing immediate support, the paramount Queen Mother of Doma, who is also an alumna, donated 200 bags of cement to get the walls rising.
All students are actually here, hospital.
The head teacher further appealed to all former students of the school to support this project in order to help make it a reality.
So I will use this opportunity to plead with all students to come to our aid.
For the students, This means no more late night scares. For the old students, it is a legacy, and for the community, it is a promise of accessible care on the Sunyani Hills. The 1999-year group has planted the flag. Now they are calling for bricks and mortar. Reporting for Joy News, Anas Sabit, Sunyani.
Women with disabilities in Ghana are calling on government to fast-track the ratification and implementation of the African Disability Protocol to strengthen legal protections, promote inclusive policies, and enhance the participation of women and girls with disabilities in national development. The protocol seeks to address the unique challenges confronting persons with disabilities in Ghana. The following report has more.
The African Disability Protocol is aimed at strengthening disability-inclusive policies, empowering women-led disability movement, and protecting the rights of persons with disabilities, particularly women and girls. Speaking to Joy News at a stakeholder engagement with disability rights advocates in Accra, founder and executive director of the Women with Disability Development and Advocacy Organization, Veronica Kofiedu, urged government to expedite the ratification and implementation of the framework to improve the lives of persons with disabilities.
It has packages that protect the rights of women and girls with disabilities. Therefore, we are entreating the Parliament to expedite action on this ratification because it is long overdue.
Member of Parliament and Parliamentary Representative for Persons with Disabilities, Wala Sikbeli, assured stakeholders of government's commitment to ratifying the protocol to help address the challenges confronting persons with disabilities in the country.
We believe Parliament will refer it to the appropriate committee for deliberation, then other stakeholders will be brought in. It's not going to be difficult when it finally arrives in Parliament for its ratification.
Disability rights advocate Gertrude Oforiwa Fefuame also stressed the need for stronger policy implementation and greater inclusion of persons with disabilities in decision-making processes.
We have a voice as women, and usually it is discounted, but this project seeks to ensure that women and girls with disabilities are part of this agenda. It is important to us.
Stakeholders say the ratification of the African Disability Protocol will mark a major step toward advancing disability rights, promoting inclusion, and ensuring equal opportunities for persons with disabilities in Ghana. For Joy News, Rakiba Muhammad's report read to you.
A business executive and philanthropist has paid the medical bills of 12 patients at the Yendi Municipal Hospital and provided meals for more than 300 patients and staff. Nathaniel Adams Jr., the Chief Executive Officer of the 7A's Consortium of Businesses, founded the initiative to mark his 50th birthday. Speaking about the donation, Dr. Adams said, having lived in the area, he was aware of the difficulties many people face in paying medical bills, reason for the gesture.
Dr. Nathaniel Adams Jr. has worked in the Eastern Corridor of the Northern region for decades and has supported communities with projects including boreholes and health facilities. He said the latest gesture was part of ongoing efforts to help people in areas where access to healthcare and basic service remain challenging. Speaking at the event, Dr. Nathaniel Adams Jr. said, having lived in the area for most of his adult life, he understands the difficulty many residents face in meeting medical needs.
I come and share with the sick. I know the challenges that people go through because of my relationship with the hospital. And yes, today, we just done with breakfast. There are people who didn't have supper. Yeah, they are supposed to have drugs, take drugs today. And they had breakfast, good breakfast. We've served over 300 breakfast. Lunch is ready. We are serving lunch, and we'll serve supper. Patients, we are serving the health workers as well as the caretakers of those patients who are here. And I am also happy that I have been able to impact or support them. This is what we have done. So far, we spent about 30,000. We're taking care of 11 critically ill people. And we believe that God would bless them and grant them healing to come out of the hospital.
The municipal director of the Ghana Health Service, Joanna Kwaku, said Dr. Adams has been a consistent source of support for the health sector in the municipality.
Dr. Nathaniel called that he's celebrating the 50th birthday and he wished that he could celebrate with the clients who are on admission and also do some donation for the needy or the special cases. But personally, I was so happy because it comes once in a time. It's not every day you have such opportunity or every day you have such thoughts from an individual. And he's somebody who have helped us and in fact keep helping us. He drilled boreholes in some of our facilities, mechanized them. We also work together with other organizations to do so, for which he done. He also supports us with his care track when we have mass long-lasting net distribution. We have huge consignment to pay. He supports us in that direction. So it's somebody, and also when you knock on his door, it does help.
Some of the beneficiaries were overwhelmed by the gesture, urging that more of such support come to the hospital.
The support, I had it today, I had it yesterday. The support. Yesterday, I gave birth. I have some partners. The doctor paid for my bills. So I benefit from them.
And we saw them this morning. We were really happy and really appreciate what they did. And then with the initiative and then the support, I think to me like this, I will benefit from it because when I gave birth, my child has a condition and I think they are going to support me with that. And I think if it's going to be a regular thing, it will really help our people because a lot of them come here and after discharge, how to pay their bills, even how to get money and feed themselves is a problem. So if it's going to be something that our leaders will help, it will really be good for the people here.
Ahead of this year's JoyNews Impact Makers Awards, slated for May 15th at the Labadi Beach Hotel, some past honorees say the recognition from the initiative is driving stronger support and expanding their interventions and reach to grassroots levels. One of them is founder of the OKV Hope Foundation, Osei Boatin. He says the award has significantly boosted support for his healthcare outreach program, reaching more than 10,000 people across 65 rural communities. According to him, the exposure has also strengthened partnerships that continue to implore and improve access to healthcare in deprived areas across the country.
After receiving the recognition from the JoyNews Impact Award, our work has received tremendous support, and we've gone ahead to win the Global Citizen Award, and which gave us additional resources to scale our impact across the country. In 2025 alone, we served 10,636 people across 65 rural communities in Ghana. And even beyond that, we've gone ahead to launch some initiatives like our telehealth initiative that has been focused on bringing specialist consult right on the doorsteps of rural communities. We've also grown our mental health care initiative that has been focused on bringing mental health symposiums across several high schools in Ghana and establishing mental health clubs across these schools.
Another awardee, Portia Dumba, says the recognition has helped secure partnerships that contributed to the rebuilding of a 3-unit classroom block in Domangri, provision solar power for households and schools in parts of the Savannah region.
The awards, the real impact has actually been in the communities. In Domangri, for instance, we partnered with Girls Lead Change to rebuild a 3-classroom block with 60 dual decks, and with support from Women Change Makers for Education, we got marker boards for these classrooms. Today, children are learning in a safer and more comfortable environment, with some getting the opportunity to sit on decks for the very first time. We have also played a major role in terms of advocacy by engaging officials from 350 Ghana to extend their solar project in Kwong in the Savannah region to help improve access to light and safety. They were able to support about 70 households with solar lamps and also 3 street bulbs. In addition, the school that was rebuilt in Domangui also got a solar lamp to help students study at night.
Joy FM's Mommy's Day Out at Crown Forest over the weekend gave mothers a memorable day of fun, relaxation and celebration as attendees enjoyed music, food, dancing and moments of bonding in honor of motherhood. The event brought together women from different backgrounds, many of whom relished the opportunity to take a break from their busy schedules and be celebrated in a lively atmosphere.
The joy of motherhood filled the atmosphere as 100 mothers gather here at Crown Forest to celebrate Mother's Day as part of the Joy FM Mother's Day Out in Gomoa to honor them for their huge sacrifices to their children, friends and families.
It's so exciting and so full of fun. I'm so happy. My son paid for me and I'm here to enjoy.
The experience is good. We are having fun. It's a nice environment.
It's a nice experience. The boat ride, the squad biking, the safari ride and all that. So it's been a great experience.
So far, so good. I get to see a zebra for my first time, and then I get to see a giraffe, known a lot about them, and even the boat riding. It was very fun.
The day was filled with activities including boat pedal, safari tour, and a question and answer session where mothers got a chance to win amazing prizes, with some children who accompanied their mothers sharing great messages to them.
It's just to bring our mom out, to expose her. She's been home for some time now, so myself and my siblings, we decided that, okay, it's a good time for us to bring her out. And as you can see, we are really enjoying ourselves, and she's also happy.
We've been listening to Joy FM since childhood, so I saw it as a nice opportunity to take my mom out, have some bonding time, explore the place.
When I looked at the program, I think it was something that would be worth bringing my wife. So on behalf of my children, just wish a happy Mother's Day, and that the kids appreciate every single thing that she has been doing for them, the sleepless nights, cooking food for them every day, making sure they look good, going to school and all that.
Our host, MP for Gomoa, Kwame Asariobing, also known as A+, pledged to offer assistance to women who bring businesses that can help in the development of Gomoa.
I'm here to support those who are bringing businesses here, and I'm going to ensure that your businesses are going to grow. There is a $500 million poultry project that is coming here. When you are ready, one day you can come and I'll take you to the sites to go for a tour. And so there are other businesses that you can do around it. It's a fully automated poultry project that is ongoing currently. It's about 80% complete.
Here is Queen Mother of the area, Nanahima Efuamrekua the First.
To all mothers, I wish you a happy Mother's Day. I continue to wish you abundant grace and favor on your lives. Thank you for bringing us into this world. Thank you for making us special, and we love and we cherish you, and we hope you continue to grow and grow in the grace of God. We love you so much. This is from Crown Forest to every mother who came and who wants to come to Crown Forest, because Crown Forest is the place to be, nowhere else.
From all of us here at Joy, we say thank you to all of you mothers for doing this with us. Let's go again next year. We wish all mothers out there a happy Mother's Day.
Well, that's it for The Pulse this evening. For more news, you can log on to myjoyonline.com. The news team returns at 7 p.m. with News Prime. My name is Kenneth. Jesse, have a good evening.